Beyond statins, mix and match. This is the topic. I'll start with a case which I had this week, and I'll take you through that. So this is a 51 years old male, came with acute infraposterior myocardial infarction, and his ejection fraction was 50%. On evaluation, he was detected to have newly detected diabetes. His HbA1c was 8.4, and his presentation, he had a stage 2 hypertension. And his lipid profile, if you see, LDL-c is 260. This is my first case, 260 of LDL-c, and triglyceride 236, and total cholesterol of 309. He had a positive family history of coronary artery disease. Father had MI, and he is a smoker. And this is the angio. His circumflex was 100%, and it was primary angioplasty was done. And the post PTCA picture you can see. So what is the LDL-c target for this individual? Here is a patient who has almost all risk factors that we read in the books. What is the LDL-c target? So let's go into the Lipid Association of India. Our own Association of India has given clear-cut recommendations based on the international guidelines, and you can see that this patient has major ASCVD risk factors, age more than 45. Our patient is 51 years old, and he has a family history of premature ASCVD. He is a current smoker, and he has high blood pressure. So he has 4 major ASCVD risk factors, and he is a diabetic, and his LDL-c is more than 190. That is, his LDL-c was 260. So does he fall in high risk? Because he has more than 3 major ASCVD, but he is a diabetic also, so he goes to very high risk. But he has presentation is MI, so he becomes extreme risk. So we have extreme risk category A and category B. Why we should know this risk stratification? Because based on his risk only we can fix the LDL-c goal. So what is the LDL-c goal for this individual who has coronary artery disease and diabetes and more than 3 major ASCVD risk factors? So here is the guideline which says that extreme risk group B category, the LDL-c level should be less than 30 milligram per deciliter. It should be below 30. So his LDL-c now is 260. We should target around less than 30. So how we are going to do this? The baseline LDL-c is 260. The target is less than 30. In other words, we have to reduce 88% from baseline value. Do we have drugs to reduce so much? So let's see what this slide shows. We have the major drugs like statins, age-old statins. Then we have bempedoic acid, ezetimibe, PCSK9 inhibitors, and bile acid sequestrants. Can high-intensity statin reduce this level? High-intensity statin daily dose lowers LDL-c by 50% from baseline. Among the statins, only atorvastatin and rosuvastatin comes in this group. Atorvastatin 40 to 80, rosuvastatin 20 to 40 milligrams comes in this group. So obviously, LDL-c below 50, we cannot reduce with high-intensity statin alone. It has been shown in JACC 2014, more than 40% of individuals who were on high-intensity statins, they couldn't achieve the target of less than 70 itself. So where is the question of less than 30? So we need to go for more drugs. So patients who are on high-intensity statins, where you are not able to achieve the LDL-c target, the statin becomes insufficient. So in that group, we have to select the other drugs like ezetimibe, bempedoic acid, PCSK9 inhibitors or bile acid sequestrant, and try to achieve the LDL-c target. So treat to target. Our initial prescription itself should be likely to reach the LDL-c target. So previously we used to start with statin, then add 1 by 1 drugs. Now the concept is combination therapy. Like blood pressure, we should straight away start with combination therapy in the initial stage itself in order to achieve the LDL-c target. If you take high-intensity statin, I told 50%, ezetimibe alone if you give it reduces by 20, bempedoic acid alone if you give it reduces by 21.7%, PCSK9 inhibitor alone if you give it reduces by 50 to 60. But if you take a combination of high-intensity statin, ezetimibe and bempedoic acid, we can able to achieve 70% reduction from the baseline. And the ultimate target is the PCSK9 high-intensity statin with ezetimibe, we can reduce it by 85%. So if this patient receives these 3 drugs, PCSK9, probably we can able to achieve the target much faster. Let's see what I have done. So this is the International Lipid Expert Panel 2023 guidelines. It says that patients who has ASCVD with LDL-c more than 160 start upfront combination of high-intensity statin with a fixed dose combination of bempedoic acid with ezetimibe, which is available today in our country, and we can start this combination high-intensity statin with a fixed dose combination of bempedoic acid 180 mg and ezetimibe 10 mg. We can able to reduce the LDL-c from baseline by 75%. So exactly I have done this for this patient. So I have started him on high-intensity statin or atorvastatin 80 along with bempedoic acid 180 ezetimibe 10 mg combination, and I have to follow this patient. I was just discharged yesterday, so probably I will call him after a month and repeat a lipid profile and see how his LDL-c is. So moving from the high-intensity statin therapy alone towards a high-intensity LDL-c lowering with early combination therapy, by that we can reach the LDL-c goal faster. And when we give a single pill, a combination of 2 drugs into a single pill, so we can reduce the pill burden, obviously, that increases the adherence, which is shown in this slide from European Society of Cardiology. So here, the first area, you can see the left side corner, patient with ASCVD and like acute coronary syndrome, this patient. So 75% we can target with fixed dose combination of bempedoic acid ezetimibe, come under control, then probably PCSK9 also. It doesn't come under, then we have like blood pressure control. We should go for combination therapy from the initial stage itself. Early use of combination therapy are needed. And we have multiple drugs. That speciality of this drug is they act at different levels. So when we combine together, we get a synergistic effect, and thereby we can achieve the goal. So to conclude, now we just need to do it. Thank you.
Thanks a lot, Dr. Srinivasan. And now we'll be having the session open for 4 minutes. Thanks for the excellent timing maintained. I think all of the doctors are keeping to the time, so very, very thankful to that. And yes, the session is now open for the Q&A.
Risk of?
Will there be any role for artificial intelligence in identifying those who are at the risk of hypercholesteremia?
Artificial intelligence in risk of hypercholesteremia. I mean, we are anyway doing muscle checkup, and LDL-c, I mean, lipid profile is available in our routine muscle checkup. So what do you mean by artificial intelligence? I don't understand.
Probably you are alluding to the need for doing cholesterol profiles along with lipoprotein little a also should be included. Random sample is good enough for LDL cholesterol and for lipoprotein little a. Only fasting sample is important for triglycerides. For most of it, a random sample is good enough. I think we should also make sure that the LDL is not measured as a formula. It's not calculated by a formula. Most of the labs, they would have given in the brackets, calculated. Don't go for that. You ask for measurement, direct measurement. Otherwise, errors will be there.
Sir,
Frederick's
sir,
formula.
regarding TGL should be reduced for cardiac risk or not? With what drugs?
There is a topic called residual risk. So TGL, say when you have achieved the LDL-c goal, and if still TGL is high, probably we should target that also, because what we call atherogenic dyslipidemia, one component is TGL. So TGL with low HDL is not good, and there we should target TGL also. But having said that, now we have a newer molecule, Indian molecule called lipaglyn, which is now well known to reduce the TGL also.
We also have got the icosapentethyl, which is coming to the market, Indian markets as well. In case you have used all the statins, they are the fundamental drugs in this scenario. Srinivasan has shown how we use the combination therapy. No more of starting and sequentially increasing. And then despite all these, the triglycerides continue to be high. You can add probably icosapentethyl as the next drug of choice because of tremendous benefits seen in the REDUCE-IT trial, with icosapentethol. The first brand is available now for the last 1 month.
How do you follow the, excuse me, here. How do you follow the follow-up of the patient, sir? How do you go for the follow-up of the patient?
Yeah. So this patient, actually the recommendation says that you do the lipid profile after 2 weeks, but I am planning to do it after a month. So what they say is after 2 weeks you repeat the lipid profile, and if you have not achieved the LDL-c goal, then you have to add one more drug. So the next will be, I have left out with only one drug now, PCSK9 inhibitor. And if that is not going, after starting that, again repeat it after 2 weeks and see. So you have to achieve the LDL-c goal.
There is not a lot of experience with long-term use of these combinations. So one is how long will you continue this with this same dose of multiple drugs? And also, what are the long-term side effects or negative effects of this combination of drugs to reduce lipid levels?
See, once we achieve the target level, then slowly we can come down on the dosage. And as we know that every drug have some side effects, so we should look for the side effects also when we do the lipid profile. Basically, you have to do an SGPT, and you do a uric acid, and you do a glucose level, and you do a creatinine, kidney function. We have to monitor the liver function, kidney function, uric acid. Basically, bempedoic acid is known to increase uric acid. Especially patients who have hyperuricemia at baseline, you have to be very careful and better to avoid it or start with the low dose. So that is one thing we have to remember. And bempedoic acid tends to slightly increase creatinine, so we have to have a close watch on the creatinine also. So basically it is like this: you do a CPK, do a creatinine, do a SGPT, uric acid and glucose. I think that should be sufficient in follow-up of these patients.